and professionals, doctors, and people in the healthcare space. Good morning. I think I joined David in saying this conversation we are having here this morning is probably the most emotional conversation we are going to have. And let me thank Professor for welcoming us to Catholic University. I also want to thank you for the appointment. I will supply my curriculum vitae and my certificates, because I think I qualify. As David has said, I have been around Kenya with my team, and there isn't a single meeting I have gone where there is, or in every single meeting I attended, including yesterday in Kilifi, you will find somebody with a picture of a loved one in some medical condition, and they are seeking for help. So, this conversation we are having here, ladies and gentlemen, we are not having a conversation about politics. We are having a conversation about life. We are having a conversation about our loved ones, people we cherish and people we love. And therefore, when we decided that we are going to have a different format of engaging in the politics that go into the 2022 election, and we figured out that rather than sit in some boardroom and draft a manifesto, we better go to every county and listen to the issues that are important to the people of Kenya. And let me give you a personal experience. Last week, we had a persons living with disability forum, and they thoroughly educated us and changed my personal view. I thought I always knew. In fact, we had put in our proposal that we are going to increase the number of special schools to take care of the children that live with disability. And to us, it looked very nice, because we are providing additional facilities and additional schools. But they told us, no, we do not want more special schools. We want people living with disability to be integrated with other kids in schools. And that was fundamental. And they told us, the more we have segregated schools for people living with disability, the more they are stigmatized. And that completely changed our plan. And therefore, it validated our approach, that while we can sit somewhere and figure out what we think is not right, there is a wealth of experience, knowledge, and ideas out there that if we gave ourselves time and provided a platform, we could actually tap into that wealth of knowledge and better inform what we want to do. That is precisely part of the reason why we are having this conversation about health. Ladies and gentlemen, the reason why we have listened to many health issues in many fora, in fact, in every fora that we have attended at the counties, matters health have always taken a prime place. Community health volunteers, lack of drugs in our dispensaries, no personnel in our dispensaries, challenges of procuring drugs, and it's been consistent. And that is why we decided that we're going to have one forum where we will discuss only health. I want to say the following as I sit down to listen to stakeholders in the health space. If there is a sector that suffers trickle down and needs a bottom up, is the health sector. Today, almost 60% of patients, instead of going to a dispensary or a health center or a level 3 or 4 hospital, they actually choose to go to referrals, because their experience is that there is no health professional at the dispensary. And if there is one by chance, there are no drugs. So if we must figure out how we are going to start at the bottom, how the health center, how the dispensary, how the community worker is going to be empowered sufficiently to be able to deal with the challenge right at the root. If the dispensary is working, if the health center is working, it's the only way the level 4 and level 5 will work. As it is, the health center is not working because there are no drugs. The dispensary is not working because there are no personnel. And the level 4 and level 5 are not working because there is congestion. Everybody is crowded there. So, if there is one thing we must figure out from where I sit, you will tell us better. If there is one thing we must sort out, is we must take health to the bottom of the pyramid. If there is one other thing we must sort out, and again we are going to listen to you so that you tell us, we must sort out the health commodity supply chain. I don't know about the wisdom of having a monopoly called KEMSA. Some people must persuade us that there is logic, there is reason why we have a facility that don't have drugs that are required at the right time, but they have drugs that stay in the stores until they expire. We just simply must sort it out, right? And you go to any health facility, you go to any county, they will tell you they have very serious challenges with KEMSA. As chair of the IBEC, we even tried to say, let the counties appoint 2 directors to KEMSA they did about 2 years ago, but we are still on the same spot. The structure of supply of drugs simply needs to be redone. And finally, from where I sit, these are the three issues I wanted to say, is that we cannot continue to write on pieces of paper everywhere, and then the next day that piece of paper has disappeared. You come back to hospital, they write on another exercise book, and then it disappears. So health records become the biggest challenge and nightmare we ever have. I am aware that we wanted to procure a health records system, digital system, that would not only give us portability of patient data, but it would also help us in the whole space of telemedicine. But because of conflict of interest and other things, for 5 years, we have never managed to procure a health system. And therefore, if there is one urgent thing that must go into our 100-day delivery, is to figure out how to have a health system that will not only capture all the health data, it will also make patient data portable from one place to another without a lot of effort, and it will also make it that much more easy to sort out commodity supply and also help us with telemedicine. So, good people, this is the conversation. This is what I think. You are better informed about this sector. I know we have people from different sectors of our health space with a lot of knowledge, with a wealth of experience. And this is the forum for us to have that conversation, because, as you've heard, 30% of our population are one sickness away from poverty. And I think that's too much of a risk. We must do whatever it takes to sort out our health issues so that we can confidently speak to the words that a healthy nation is a wealthy nation. It's the only way we can take our economy to the next level. So, ladies and gentlemen, welcome to this conversation. I just thought I should, without necessarily directing what you have to say, but to also give you my personal experience from where I sit, and my personal experience as we went round with my colleagues here to various parts of the country. Karibuni sana. This is a very important conversation, and I agree with David that everybody should go away with a photograph to remind you that you are at the place where finally we sorted out the health challenges of our country. Asanteni sana.
Kindly let's give our chief guest a better clap. Thank you very much. We now move to the next session, where we are going to invite different leaders in the various sectors. And I will start with Mr. Simon of the Kenya Medical Association. We will not have any specific order or priority, because all of us We want the best for this country, and therefore we are all equal in trying to share our thoughts in the health sector. And therefore I'll invite Mr. Simon Kingondu, after which we'll have Dr. Timothy Olwen of the Kenya Association of Private Hospitals, and then we'll have the third person, who is Mr. Tony Kirwa, who will represent the referral hospitals. Thank you. I'll kindly guide us. For those of us who are closer to the back door, the washrooms are ground floor, so you'll just get out, go to the ground floor. There are stairs on both sides. And those of us who are seated in the front row, we have our station next to me. For the gents, we have on this side, and for the ladies, we have it on this other side. And the rest of us, we can use, we get out on the stairs on both left and right, downstairs. Karibu sana, daktari.
Honorable Deputy President, all protocols observed, and my fellow health workers, I want to thank the team for inviting us to this forum. We will be presenting this to all stakeholders because everyone is a stakeholder in health. My name is Dr. Simon Kigondu, and I'm the recently elected president of the Kenya Medical Association. On this presidential side, we are waiting to see the outcome so that I can welcome fellow presidents soon. So I don't know who will be the president. So I am waiting for all of you there. I'll be very short. I am very passionate about what is called human resources for health. Human resources for health is all medical professionals. And just to use the so-called bottom-up approach that this team has decided to take. When I was the medical superintendent at Isiolo District Hospital, hospitals were run by the hospital and health management teams. And the team consists of the whole team, which, with the doctor at the head, consists of all other health workers. We have the chief clinical officer, the chief nurse, and everyone. And everyone met in a meeting like this to make decisions for the health sector. The so-called devolution of health actually centralized healthcare. They removed the power from the health workers at the institutions and centralized it to the governors. That is not devolution of health. What we had before, where the health workers were leading the health sector, was devolution of health. I will finish with another important statement. They devolved the wrong thing. They devolved the health workers. You will hear that all of us asking for what is called a health service commission. A health service commission is devolution. And just to illustrate this so that I don't take too much time, I have been a worker of Kenya. When I finished from the University of Nairobi, I was posted by the then Health Service Commission, which was the Public Service Commission, to Machakos District Hospital. I worked for 3 years. The government was good enough to bond me, but educate me to become an obstetrician and gynecologist. So I was paid for by the government of Kenya and came back to school for another 4 years. But they bonded me. When I finished, I was sent back to Isiolo District Hospital to be the first gynecologist there. For 5 years, I ran that hospital with my team. I had a wonderful team, pharmacists, clinical officers. The hospital was the center of the health system. The community health workers used to report to us. We give us guidance. We ran all the dispensaries together with the director, DMOH, and that was devolution. In this day and age, it would not have been possible for me to be posted to Isiolo. After Isiolo, I was posted back just before devolution, and luckily before, because currently where I am at Murang'a County Government, I cannot move because people have decided there is no Health Service Commission. Health workers are a property of the state. They are not a property of county governments. And when they can move between here, Kericho, Kisumu, that is devolution. Let us not be fixed on this, oh, health workers are against devolution. The fact that I have worked in Cumberland, Nairobi, Isiolo, now I'm fixed in Murang'a because of what they call devolution is not devolution. So, Deputy President, the Health Service Commission is all we are asking for. Thank you very much. Yes.
I've actually discussions about the Health Service Commission. And you look familiar, probably we have met, you know. Yes. Tell me, if we have the Health Service Commission and we have health services devolved in a manner it's understood in the Constitution, that counties are responsible, they employ, they promote, they can fire. How do you propose we go about the issue of you being on a payroll of the Murang'a County government, but being available to be deployed elsewhere to another county facility or to another national facility? This movement, how do you want us to balance between the counties as your employers currently and the national resource that you talk about, which I believe in, by the way? I believe there are certain regions in this country that do not have sufficiently trained medical personnel. And unless we have affirmative action at the national level, they'll continue suffering. So do you have any draft documents on the establishment of the National Health Commission and how it can coexist and blend with devolution?
Yeah, actually, thank you very much for that. That I am what is it called? Property of the county government in terms of healthcare is what needs to stop. When you have a Health Service Commission, you are an employee of the Health Service Commission, not the county government. But that does not mean the county government cannot employ. The Nairobi City Council had employees. If you find an area where the Health Service Commission cannot fit the person, then the county government can actually employ. The current scenario we are having is a situation that is not tenable in health. Which counties of the 47 have trained a neurosurgeon? None. None. Does that mean that the people at the counties do not need neurosurgeons? No. Previously, you are sponsored by the government, neurosurgeon, they look, Rift Valley, this particular area does not have a neurosurgeon. Post them there. He goes, capacity builds, and he can even now go to someone else. So that is not a quagmire. The devolution of health as it was, county government was supposed to deal with primary health care. It was correctly devolved by the legal paper of 2013 February by His Excellency Mwai Kibaki. But the politics of the people devolved health workers in a rush and illegally. We have written a lot about this, but that is not the point. The point is this. From a long time ago, for instance, when nurses were trained, their first 3 years were in Wajir, Garissa, Mandera. Why? Because it was difficult for Wajir, Mandera, Garissa to produce health workers. But the service is needed there. So the government trains you. You go work there for 3 to 5 years in your formative years so that you develop empathy that health workers need. All the nurses in their 60s currently are very empathetic nurses. They have served in far-to-reach areas, and that develops the human being. Then after that, you can go back to your home area or whatever, and it works very well. What we are having now currently, we're having public service boards employing people on the merits of their tribe or who have paid. That is not a sustainable system for this country. We are having medical interns who are in their 8th month without posting. They haven't been posted. How can you have your knowledge in medicine would have gone, and yet the state has used. David D can calculate how much you have used to train that particular, because there is no health service commission. When I finished, I was posted immediately to Machakos. When I finished, I became a medical officer, and then after that I was trained as a gynecologist. That's a resource. This country should not be practicing poor medicine for poor people. They should be training the people. You should be having continuous specialization. And this can only be done within the context of a health service commission and an organized health system with health workers at the leadership, not the politicians. COVID came. Initially, politicians tried to run the COVID program. It was a disaster. When they engaged the health workers, and specifically the Kenya Medical Association and Kenya Clinical, I can see my colleague here, Kenya Clinical, and the nurses, COVID was managed well. But professionals cannot be removed, then you expect a health system to function. So, a health service commission is not anti-devolution. It actually helps devolution. If I wanted to go and serve in deputy president's place, today I can't. I'm locked in by a county government. Muranga will refuse and say, no, this is our person. We're having people not being released to go for postgraduate training. We are not having specialization of the other cadres because we do not have a coordinated way of managing health, which was there before. And one more thing that I forgot is that we need to set aside funds for research and granting. If you do a research on the health system, then you will move away from political statements like devolution of health is good, with facts. The facts are on the table. A health workforce that is mobile and can serve in various places and linked to the various referral centers is what you require. And that can only be done by a health service commission. And we have a bill for that. We actually gave that bill from 2012. We wrote the health service. Not even that. The health service commission was in the constitution 2010 and it was removed in Naivasha when the ministries came in and they refused to operationalize it. So health is wealth. We do not have health of this political party or health of this individual of this political. Health affects everyone. Yeah?
Just one question. Yes. Listening to you, Steve, and I can see the passion you have in what you're saying. But let me ask the following. As I have worked with many governors in my capacity as chairman of IBEC, that brings together the county governments and the national government on matters to do with budget and economic issues. Now, I listened to the governor, for example, of Mandera, and his biggest argument for success in devolution of health is that they never had a doctor for a long time. Now, he has hired a record number of staff. I can give you the figures. And that for the first time, they even had a cesarean section performed for the first time in Mandera because health was devolved, right? And their argument of the other side is we must not make health a privilege for those who can afford. We must make health available for everybody, irrespective of where they are. And the only way to keep a health worker in Wajir, for example, is if you have hired that health worker in Wajir itself. Otherwise, within a very short time, they will migrate. And they have data, you know, to support that people make technical appearances in the areas where there are challenges, and everybody wants to come to Nairobi and the big towns and do their thing there. So, you know, to an ordinary person in El-Wak who now has a nurse or a clinical officer in El-Wak who has never been there, yeah, until the counties came, how do you persuade them that devolving health has actually centralized it rather than devolved it? You know, I'm talking about a practical situation.
Can I add?
Okay. Just hold on.
Let me add. Thank you very much. I am so glad that we are having this conversation the way we are having it, and that it is an emotive conversation. And those are the things which need to come out. So I want also to speak from the other side, as you have, but really to add actual data to what you have said. I have data here which I used, I was working with when we were doing the Constitution. And luckily I found that I still have it. It compares the distribution of health infrastructure between Kiambu and Tana River in the year 2007. Kiambu then had a population of 800,000 people, and Tana River had a population of 220,000 people or so about. In terms of facilities, Kiambu had, they were matched. In fact, Tana River had more facilities per capita than Kiambu because CDF had already been building facilities. So Kiambu had 2 public hospitals, 11 health centers, 523 health beds, and 14 dispensaries. Tana River had 2 hospitals, 4 dispensaries, 221 health beds, and 29 dispensaries. So you can, Tana River had more dispensaries because of CDF. When it comes to health workers, Kiambu had 6 consultants, Tana River 0. 15 MDs, GPs, Tana River 0. 1 dentist, Tana River 0. 1 pharmacist, Tana River 0. 22 clinical officers, Tana River 4. 84 registered nurses, Tana River 5. 336 community nurses, Tana River 38. Kiambu had 31 lab technicians and Tana River 2. This was Kiambu district, which is smaller than Kiambu County now. When I did some research and tried to establish the reason why, is because in a centralized system, doctors preferred the places which were closer, of course, to Nairobi. Because, and Kiambu was the most preferred because it had the most opportunities for working in private hospitals in Nairobi and elsewhere after hours or even during working hours, what doctors call locums. Yeah? So that's the other side. The fact that a centralized system, particularly where you have lack of transparency and, let's say, to be honest, corruption, the business of posting health workers in house was very lucrative, so that health workers can be posted to the places which are more favorable to them. These were the conversations we had during the bombers chats around the Constitution. One of the most striking things I remember after devolution was seeing a tender by the county government of Garissa or Wajir very early on, and they had advertised for 30 maternity facilities, what you call like maternity hospital type things, facilities. And I said, these people, how can they build 30 maternity facilities in one fell swoop? But when I read the document in a little more detail, I realized that each of them was 6 beds. So what the county government was doing was taking the services closer to the people, while in a centralized system, it is more likely that one big facility would have been built, because that's the kind of facility that brings the sort of sophistication that health professionals want. So we have this tension between downward accountability and the sense that health professionals feel that they should be one body. And to point out, having a system with a health service commission, even if it goes all the way down, or something which is accountable to the top, we call that decentralization, not devolution. Because that is a decentralized structure, but it is parallel. Secondly, the idea that you have the state, there's a sense of conflating, a hearing of conflating the state with the national government. The state includes county government, and in fact our constitution is very clear that they are 2 distinct entities but are complementary and they should work together. That's a long sort of framing of the question. I do believe, how do we square the circle between, I think, what health professionals see as works for them in terms of service, professional development, and doing their work in the way that they think they should have some professional autonomy, and the downward accountability and dealing with the governance issues of the fact that in our own self-interest, we would like to work in the places which are most convenient, which are most lucrative, and where we are not as subject to sanctions for non-performance or for other things as we might be. And I believe there is merit in both sides. How do we then square that up? I believe, and I think as a matter of principle for us, that it should be possible for having a system which meets the professional development and that kind of thing and of health workers, but is also accountable where they work. So that perhaps, I don't know whether the health service, we can have a health service which employs, so that you're in the employment, the public service, but you have an internal market that you then have to be given a contract by a county. And if the county terminates your contract, you go back and you are, there are some organizations, the UN works like that these days. You are employed by the UN, but you have to get a job. But if you stay for so long and nobody wants you, then you have to leave. Because to be honest, we cannot turn the clock back. The process of amending the Constitution so that it can look what the health workers want to do. Let me finish. Cannot happen. The task in front of us is for to figure out a system that makes doctors accountable where they work and that they can be sanctioned for non-performance. Let us not pretend that doctors are angels. And let us not have any people stand on moral pedestals or professional pedestals and say we are the only ones who know how this should work. Let us be modest. As I said, we do need a healthcare system, but we also need governance. And I think what I want to hear from doctors is how do we deal with the governance and accountability and performance challenges of having a system which people are not accountable where they work and they are accountable to something they control. That's not the normal way that employment works.
And thank you very much for this question. And for so long, this has been the issue. The doctors, actually health workers, you must have a health system, and COVID brought out that well, that is centered around the health worker. For so long, we have been sacrificial lambs. You can as well die, but the politician has said, oh, I have a doctor there. We must move out of this number thing. The governor of Mandera claims this number of doctors, and county governments have done a fantastic job in health, in employing people and all. But the cycle, look at my cycle. If I was in devolution now, I would never have become a gynecologist. Think about it. I would never. I served the people of Machakos for 3 years. Then they said, we can now proceed you in your professional development, train you, but still work for us because we have paid for you your fees for a short time. And then after that, whatever you do, wherever you become a consultant, wherever, you can still continue being a public servant if you want. Yeah? But you have served your time. But you have looked at the bigger picture. In future, we will need a gynecologist. In Isiolo, which did not have a gynecologist. So, and that was before devolution. So even me, I can come and say, Isiolo had no gynecologist. Before devolution, by the time I left Isiolo District Hospital, it was an internship center, 4 consultants, 10 doctors. Also say that if I am to run the same, but the system as it is now, even as the counties claim to employ people, does not allow professional development and specialization and betterment of health of this country. It can't. Now that the governor is gone, and I'll give you a good example. Kenyatta National Hospital is employing medical officers with contracts which say that you cannot go to school. Professional development of medicine in whatever area you are, you must have continuous development. You cannot stagnate there forever. And I'll tell you the problem we are having now. I'll use a simple, the basic doctor. The basic doctors have been employed. They work for their 3-4 years. Then when they want to go to school for specialization, they are told, by the way, that position that we have, we do not have someone to replace you. So they are stuck. You cannot employ someone because county government is saying there is a payroll. If you had a health service commission, this doctor, medical officer, is released to the health service commission. The health service commission provides a health worker for that position. This guy continues for training. The service continues to the people. Yeah. And when he finishes, we now look, Mandera hakuna neurosurgery. Went, and you post him there. Mandera will never sponsor a neurosurgery. It's too expensive for them. Yeah. So I think with that, yeah.
Thank you very much, Simon. Again, I appreciate your passion in what you're saying. And that's why this conversation is very important, so that we can listen carefully and avoid making political statements that are convenient when we actually have a challenge that we haven't addressed.
Yes.
it is very clear that there is an issue, and we need to figure out how that issue can be dealt with going forward. Listening to you, Simon, I'm just wondering, it is true, and by the way, what you have said is correct, because it came to IBEC, and many counties were saying, we have doctors who want to go at the county's expense to go and continue their education. So we have to do two things. We have to pay for this doctor to go learn, and then we have to hire another person to do what he was doing. So the counties were asking, this is too much. We cannot have it. We cannot carry, you know. So I agree with you that there is a challenge. Counties saying they do not have the resources to do that, to give you a bursary or a grant, a scholarship to go learn, and then hire somebody else. Is it possible for us to figure out how we can continue career progression, we can continue to train more personnel, more doctors, more neurosurgeons, and all the other health professionals in the context of devolution, or we must completely get out of it? I think we need to find a middle ground, a balance between those two. If we do, we will not only satisfy our health workers, but also keep devolution doing what they are doing. And Daktari, I am sure you agree that devolution has done some things right. Yes. You agree with that?
Totally.
Yeah? So we just need to correct what they have not been able to do. And I agree with you 100%. That issue came to IBEC, where counties were saying, we don't have the money first to give a scholarship. And even if we did, it means we have to hire somebody else to do, because, you know, going to train for a postgrad is not going to take months. It's going to take minimum 3-4 years. So for those 4 years, somebody must deliver the service. So while I agree with you that a health commission who has a bigger deployment of doctors would easily replace that doctor from somewhere else, but we need to contextualize it around what we actually have now in our counties. And I think there is a possibility of having a conversation that will give us that balance.
And Dr. David said something that I really need to correct. There is no problem with a doctor working in Nairobi, wanting to work in Nairobi. Why? The terms and conditions, availability of social things are there. So it is upon the government to ensure that out there, you create an environment that allows me to have my children with high quality schools and things like that. Therefore, it's not a problem for people to move to a place where they want a betterment of their family. And on that note, currently as we speak, medical health care workers working for national government have better terms than we in the counties. People of my age, I've worked in
contemporaries.
My contemporaries, I have better terms of service at national and Nairobi than in county. Then why should you then expect me to be the sacrificial lamb? I'll give you one example. When they devolved, mortgage was not devolved. Mortgage was left for the national government employees. There is no county which is on a facility, despite them being taught by national government before devolution how to. We don't have. Then you expect your colleague has a house, you are there working in the county, your pay is less, your benefits are less, you have less access to social amenities. So for government, DP, it is the role of government to equalize health workers. And when I worked in Asal, the day I was posted to Isiolo, my house allowance was reduced by 30,000. But we were posted with someone in another area whose allowance is that. Then people complain, why do people want to come? Because of these disparities which have not been addressed. So you're treating people differently just because they work in different countries, yet we are qualified the same. Yeah. So in terms of progression, I think it's very important for government to equalize what the health workers are doing.
Agreed. Agreed, Simon. Relax. Agreed. Asante sana.
Your Excellency, the Deputy President, the Kenya Kwanza leadership, all distinguished guests who assembled here today, including our host, the Catholic University. I'd like to first express my appreciation and express my gratitude on behalf of Kenya Association of Private Hospitals for inviting us to this forum. My name is Dr. Timothy Olweng. I'm the Secretary General of Kenya Association of Private Hospitals. I'd like to share a few perspectives. I had a brief presentation which was shared, but apparently they have some challenges with projection. So I'll just speak off the cuff. Now, in terms of what we would request anybody who potentially is going to be in government is in terms of certain changes that would improve our healthcare system. For example, universal health. Universal health coverage is one of the topical issues and one of the most important things. So there has to be measures put in place in terms of accelerating the achievement of universal health coverage. Now, just to elucidate a little bit, the term universal health coverage is not necessarily fully understood by everyone. Universal health coverage has got three important facets. First, in terms of providing equitable access. It's not just access, but equitable. In our country at the moment, we have got access in general, but it's not equitable in terms of, there's a lot of regional disparities in terms of accessing healthcare. Access to health services and the entire range of health services that are required, but also they have to be of sufficient quality to be effective. Because in the absence of them being of sufficient quality to be effective, at best we can talk about universal health care, but not coverage. Now, one of the things that happens whenever we try to push towards universal health coverage is one of the easiest things to increase is access. So for example, if overnight we got the resources and we said the entire population can be able to go to health facilities and get health care, health system capacity cannot increase overnight. And so what has happened, even in our case, in the time when we have had this push towards UHC, is that quality has dropped. Because health system capacity you cannot train health workers, for example, you cannot build facilities and have the diagnostic facilities and so on overnight. Then in addition to that, there's the issue of financial risk protection. And this is one thing that the earlier speaker, especially Dr. David Ndii, brought up. We cannot be exposing people to financial hardship on account of procuring health services. And the only way that that is going to change is if we change the system via which we finance healthcare. Now, healthcare financing, for example, to achieve UHC, you can have two approaches. You can have a tax-based approach, where the government primarily is the provider of healthcare through taxes, and then you can also have social insurance as a vehicle, which is the avenue we're trying to use in Kenya. Now, in the absence of us having a pooling system where we're going to pool resources, we will never get rid of the issue of people being impoverished as they seek healthcare. So the pooling mechanisms can be through, for example, tax-based systems or social insurance, as I said, but we have to eliminate the issue of paying for healthcare at the point of service. So we have to have a pre-financing mechanism, and pre-financing mechanisms only work when you pool resources, either through social health insurance or through private insurance. Out-of-pocket payments need to be eliminated. In fact, in our country at the moment, I think the data that they have from the medium-term report on the Kenya Health Sector Strategic Plan said that still we have got 8% of our households that are spending monthly more than 10% of the total health expenditures on healthcare. And that goes all the way to the point where we've got people who are being impoverished by procuring health services. The social health insurer, that is NHIF, there have been a lot of reforms that have been proposed of late, and it is in terms of trying to increase the pool or the base of people who are contributing to this fund. Now, insurance is about keeping your promise. And I don't think there's going to be any way, and I challenge anyone to if you're going to put a mandatory system and say you're going to start arresting people who don't have NHIF insurance if they can afford to pay for it, it has to be that we deliver value and people see the benefits of belonging to this system. And NHIF has periodically has fallen short of this promise. And that is a challenge. Now, you have got the biggest challenge they have in terms of financing. You talk about mandatory contributions, yes. But the challenge is, and especially during the COVID period, we saw that there was a significant reduction in the voluntary contributions because people just didn't have the money or didn't see the value. So you've got people who contribute periodically when they perceive they are going to benefit. And that aspect of adverse selection is what even private insurance companies complain about. So people go and procure insurance when they anticipate a need. And after that has been taken care of, then they stop contributing. So one of the things that we have to do is look for a way in which we're going to have consistent contribution towards this scheme. And that's why the issue of the indigent people, I don't like that term very much. I think people who are, I'll say, economically disadvantaged should have contributions provided by government. So that's one of the ways in which we're going to increase the tax pool. But even as we talk about employers also contributing or matching their contributions that has been suggested, we have got to see an increased milieu of benefits. And that is what we have not seen in the current system. We have seen enhanced contributions, but we're not seeing the enhanced benefit packages being rolled out. Now, I've talked about out-of-pocket payments. Now, the other thing is the rising cost of healthcare. This is one of the items that we have got to handle and handle decisively. There has to be a systems approach in terms of dealing with this because it is not a simple fix. I come from the private health sector, and we have always been the bashing people, boys. When it comes to cost of healthcare, they say private hospitals are the ones who are charging too much. But the inputs, if you look at healthcare as a product, the inputs that produce that product, a lot of the time, we don't determine the cost of those. And that's why there has to be a collaborative effort and a concerted effort to bring down these costs. For example, it is not a secret that since, for example, we had unionization of healthcare workers in this country, the costs of payroll and costs of employing health workers have gone up. And that is a fact. We've got other inputs. For example, pharmaceutical supplies are a significant component of the health bills we pay in this country. Why is it, for example, that when you go to a place like India, we pay for the same branded drugs that you'd buy here for 3,000 shillings, you can get it for 600-700 shillings. I had an experience like that as a doctor when I went to a hospital in India, and I started looking at the packaging, wondering whether it's a genuine product they had given me, and I could see the pharmacists getting irritated, because for me, I could not believe I was getting it at the price I was getting it. So in the absence of us having a manufacturing sector that is robust, in the absence of government somehow entering the fray and trying to be able to regulate the prices of these commodities, we are not going to control the costs of health. In addition to that, there are other drivers of healthcare costs. All commodities. For example, government has a role to play. We have got a lot of taxation right now on a lot of the inputs that are coming in for the health sector. We cannot say that we are trying to promote universal health coverage, and yet at the same time we are taxing the inputs that are going to bring down the costs of healthcare. I come from the private health sector, and we have seen in other sectors, for example, the government gives incentives. You've got people who get tax holidays when they come and invest. And the rest of us who are local investors are sitting and wondering, why would the foreign investors get preferential treatment over us? And if I was a foreign investor, before I come and invest in a market, I want to see how that government is treating its own people, because that becomes a reflection of how I'll be treated a short while down the road. So the cost of healthcare has got many facets, and that needs a concerted effort in terms of bringing down costs. One of the other major things is the mechanisms we have for healthcare provider compensation. For example, the traditional method, especially in the private health sector, has been fee for service. You walk into a facility based on the inputs that are used in terms of providing care for you, a bill is generated, and that's how you pay for it. At the other end of the scale, the extreme end, we have got a system which we call capitation, where we decide that there are a certain number of people we want you to take care of their healthcare needs. We decide on a certain amount, we provide it to you, and in that way the risk has been transferred to you. So that's a capitation system. In the recent past, we've also got a fixed fee for service system, which especially private health insurers have been trying to introduce, and which the private sector feels is very unfair in the sense that they're transferring the risk of taking care of the clients to providers. and a lot of the time without notifying the clients that that is what they're doing. So you're told, we'll pay you for every outpatient visit 2,500 shillings. The person who is coming for care has not been told that's the arrangement, but what happens is the tendency is people try to reduce the cost of care per individual, and therefore quality of care goes down. And that is something I think we should not encourage in our system. The other thing which determines the healthcare and where government has got a major role to play is what we refer to as social health determinants. There are certain things, for example, socioeconomic factors that have been known to be associated with poor health outcomes. For example, the level of education has a bearing on people's health status. What kind of jobs they have, what kind of income they have, the kind of environments they live in, and other health behaviors, for example, smoking, their sexual habits, alcohol use, and so on. So you'll find the truth of the matter is the determinants of health that are within the control of the individual are actually a very small percentage, between 30 and 40%. The rest you're actually relying on other people. For example, as an individual, you cannot change the healthcare system in which you go to